Education and Community Outreach here at the Center for Innovative GYN Care. And today we're going to unravel some pervasive myths about endometriosis, the symptoms and treatments that revolve around it. And joining me to do so is Dr. Natalya Danilyants, also known as Dr. D. Dr. D is a board-certified, fellowship-trained, minimally invasive GYN surgeon and co-founder of the Center for Innovative GYN Care here in Rockville, Maryland. Dr. D completed her residency at George Washington University, where she served as chief resident and received fellowship training in advanced retroperitoneal laparoscopic surgery through the exclusive Johnson & Johnson Ethicon endosurgery program. Thanks so much for joining us today, Dr. D.
Thank you. Thanks.
So Dr. D, I know you often receive various questions about endometriosis in your clinic, and sometimes patients may share a new alternative treatment for endo that they heard about from a friend or online. Could you tell us a little bit about, I guess, the most common myths that you hear and kind of why you wanted to do this live today with us?
Sure. You know, the most common question is, which comes usually from young women in their teenage years, so 16, 17, 18, am I too young to get endometriosis? And that question typically stems because another provider told them, you know, you're too young to have laparoscopy, you probably don't have endometriosis. So it's not even that they're getting this information online, but they're getting this information from other providers, which is definitely not true. You can, typically endometriosis starts in the early years. Another question is, you know, about different alternative treatments, like vaginal steaming, for example, in patients who we already have the diagnosis of endometriosis. And in some cases that endometriosis is quite severe, and they're sort of inquiring about these alternative treatments that, you know, we'll cover a little bit later, but they're definitely not effective in their situation.
Okay.
Yeah.
And so I like to point out that, and I'm really happy that you said that it's not only the internet that they get this information from, so it's also other providers. But when the internet is the primary source of news and information for most of us, we don't have this natural filter system built on our devices that will tell us what is fact or fiction. So it's so much easier for us to possibly be misinformed. And so the purpose for today's live is to provide clarity on the claims related to endometriosis to really ensure that everyone has the accurate information they need to make the best treatment decisions for their health. And what better way to address this information discrepancy than to have a conversation with a GYN surgical specialist like yourself, Dr. D, that sees endo cases on a weekly, if not daily basis. So I think this will be really insightful. And the way this is going to play out is we're going to first start off with going over the myths of the causes of endo, and then we'll jump into the characteristics of endo, and then we'll close off with the treatments revolving around endo and whether or not it can be cured. But before we jump into that, I wanted to turn to our viewers and ask you to leave a comment below with what you've heard about endometriosis, and we'll make sure to address your comment later on in the live. So let's get right into it. First, I'm going to mention two myths that we commonly saw online on the causes of endo, Dr. D. So the first one is tampons cause endometriosis. And I'm just going to go ahead and say the second one now too. Endometriosis is a sexually transmitted disease. So could you share the truth behind the cause of endometriosis? Do we know the cause?
Yeah, so we don't know 100% what causes endometriosis. So there are sort of two main theories. One is the retrograde flow of the menstruation. So the endometriosis, the word endometriosis comes from the word endometrium, which is the lining of the uterus, which is what sloughs off or sheds every month when a woman has a period. So those cells can travel through the fallopian tubes sort of backwards and implant in the pelvis. And then they attach to the pelvic structures. And then every month, typically during a period or around the period, they cause a lot of inflammation and irritation, which leads to pain. So that's one of the theories. Also, there's another theory that the same sort of implantation of the cells, but using like the lymphatic system. And then also exposure, some environmental exposure. So even in utero, so the mother, right, is exposed to certain environmental factors that then leads to development of endometriosis in the newborn. Or it might be exposure of the patient to all these environmental factors. So no one really knows the actual cause of endometriosis. We know that women, for example, who've had a hysterectomy can still have endometriosis, even though they don't have a uterus anymore, because of the stimulation of the hormones from the estrogen. Even if you, let's say at the time of the surgery, take out the uterus and take out any visible endometriosis implant, endometriosis can still come back as long as the patient has ovaries. So then that whole theory of, new retrograde menstruation and new implantation of these cells would be incorrect, right? Because this patient doesn't have a uterus anymore. So there's probably multiple factors, and we'll probably never know exactly what causes endometriosis. So the main focus has to be on the treatment and on an appropriate diagnosis, so that the treatment is not delayed and endometriosis doesn't cause permanent damage to the organs or infertility.
Absolutely. So I'll just jump into our next myth so the next myth says endometriosis can be cancerous or lead to endometrial cancer. So if I'm a patient that has endometriosis, is it likely that I'm going to have endometrial cancer as well because I have endometriosis?
No, so endometriosis does not lead to endometrial cancer. So endometrial cancer is cancer of the uterus that originate in the uterine lining. So it's not because that lining is growing somewhere else outside of the uterus. It's the cancer that's starting in the lining that's in its correct location. And typically, women who are at risk are, who are obese, postmenopausal. So there's extra production of estrogen without constant shedding of that lining. So presence of endometriosis does not increase the risk of endometrial cancer.
Okay, thanks for clarifying that. So our next myth is kind of taps into the risk factors of endometriosis, particularly age. And it says you can only get endometriosis past age 30. So I'm just going to chime in on this one before you do, Dr. D, and say that in 2018, ACOG, which is the American College of Obstetricians and Gynecologists, they published a committee opinion, and that's basically just this document that provides guidelines on diagnosis and treatment for OBGYNs and GYN specialists. And in this particular case, it was on endometriosis in adolescents. And what they concluded was that endometriosis is the leading cause of secondary dysmenorrhea, which is painful periods, in adolescents. And they also said that 2/3 of adolescent girls with chronic pelvic pain and dysmenorrhea will be diagnosed with endometriosis at the time of laparoscopy. Now, this is obviously for girls who don't respond, who haven't responded well or don't respond well to hormonal therapies and pain medications. And in addition to that, there's also a recent study that was published in July of this year, and it was published in the Journal of Pediatric and Adolescent Gynecology. And they found that the prevalence of endometriosis in adolescent girls was very high. So this was a meta-analysis, and that's basically when they're looking at a bunch of different studies. And in this case, they looked at 231 international studies, which consisted of a little over 1,000 adolescent girls who underwent laparoscopic surgery for confirmation of endometriosis. And 64% of those girls were found to have endometriosis. So the conclusion was that adolescent girls are just as likely to suffer from endo as an adult woman. And I guess you can speak to that as well, as in terms of what you see at your practice.
Yeah, I mean, I've definitely seen very young women with endometriosis. The youngest patient I had was 14 years old, and her and her family have been to multiple providers who, told her that she's too young to have endometriosis, and she was on birth control pills. She was doing kind of the typical treatment of painful periods, which wasn't working. She was even having to do homeschool because she was in so much pain that she was not able to go to school. This was, obviously before COVID. And we did laparoscopy, and she did have endometriosis, and it was actually much more advanced than I would have guessed, given that she was so young and that she just recently started having her period. So it's not that she was menstruating since she was 9 years old. She literally had only been menstruating for maybe 6 months. So, it definitely can happen early. And I think, the delay in diagnosis, it builds a lot of, frustration in the patient, a lot of mistrust towards the medical providers.
Yeah.
It can lead to anxiety and depression because, when you're 15 or 16 and, you're a teenager, it's so hard, especially now with social media, and Instagram, and you're already trying to fit in and look like what you're supposed to look like, or you think you're supposed to look like. And then to add on top of that pain where no one is recognizing or is willing to believe is there, I think it's definitely can create some long-term psychological damage, and also, of course, impact the physical life, right? Inability to participate in social activities, in school, to have friends, to really enjoy life and enjoy what it should be, kind of the fun years. So yeah, I mean, it has a lot of impact, and there's really not a lot of downside to doing laparoscopy. So you mentioned, 2/3 of adolescents will have endometriosis at the time of the laparoscopy. So 1/3, may not. And I think that number is maybe even lower because, a lot of laparoscopies are being done by generalists, and there are lesions that they may look atypical, or they may not look like endometriosis. So I think it's probably even underdiagnosed. That number 1/3 is probably lower in reality. So there's no harm. The risks of doing laparoscopy are very low, but the benefits of actually diagnosing endometriosis earlier in life are so high that I think, it should be recommended much more than it is in younger patients.
Absolutely. And so just to clarify, essentially, once you get your period as a young girl, that's when anybody who has their period can be at risk for endometriosis. Is that true?
Yes, because, regardless of what theory, there is, we know that it's estrogen dependent, right? The endometriosis depends on the production of the hormones by the ovaries. So even if we think those cells get implanted earlier on in the development, or if they implant, with the period, really once the estrogen kicks in, again, whether or not those abnormal cells are already there, that's when they kind of start getting stimulated and the symptoms begin. I think it's not wrong to start someone on birth control pills for, a few months to manage some of the symptoms, but you also can't say like every management fits, all the patients, because some patients who have very severe symptoms, you wouldn't want to delay their treatment because you're trying to follow this specific path of birth control pills first and pain medications first. If you see somebody is really suffering and has very, severe symptoms with ER visits and vomiting, you probably with that patient, you're going to be much more aggressive with offering surgical treatment earlier on, rather than someone who just has some cramping for 1 or 2 days.
Absolutely. And every case is different. There's not like a one size fits all management approach.
Right.
I see we have an audience comment and question, so let me address that before we go on to our next myth. So we have a comment. I have had my uterus removed in 2011, found out I had a severe case of endometriosis. I had my right ovary removed in 2014. The doctor couldn't get to my left ovary. I have had always an unknown issue on my left side of the ovary.
Yeah, I mean, typically with severe endometriosis, definitely, sometimes surgery can be very difficult because of long-standing endometriosis, because it causes inflammation. Inflammation leads to scar tissue. So it's like, you hear of people having ruptured appendix, right, and being sick for a long time, and then the surgery is much more complicated, and then they have to be in the hospital, and then they develop scar tissue. So endometriosis creates constant inflammation, constant bad environment, which leads to scar tissue. And scar tissue is what makes surgeries more difficult. But not having the left ovary removed continues, the endometriosis doesn't stop, right? So you can have even a small part of an ovary left and still have continued endometriosis. So that ovary would need to be addressed in order to kind of put an end to endometriosis, for sure.
That's a good point.
It sounds like it would require a specialist to address this. And then in terms of the endometriosis associated with degenerative disc disease, it's more of a treatment. So a lot of patients who have severe endometriosis are put on medications that increase your risk of bone thinning, right, and affect the bones and the spine and the hip. So osteoporosis or osteopenia is not uncommon with some of the treatments like Depo-Provera, which is an injection, and then long-term treatment with anti-estrogens like Lupron therapy or Orilissa. So with all of those treatments that are long-term, so for many years, it can definitely lead to bone thinning even in younger patients.
Okay, thank you for that. And could you also talk a little bit about the prevalence of endometriosis as a secondary condition? So for example,
So, one of the myths that I've come across is that, endometriosis is more prevalent in white women. So you have fibroids for Black women and endometriosis for white women, which creates a problem because, unlike fibroids, which are diagnosed by ultrasound, so it certainly would be easy to rule out that, yes, you have fibroids or no, you don't. With endometriosis, you cannot tell. So you can have absolutely normal imaging with normal ultrasound or a normal MRI or a CAT scan. So everything looks great. That means you don't have it. No, that's not true. And when you then go a step further and start to sort of dismissing one group of people because you believe that it's just not very common in that group, you're just going to, further worsen this diagnosis issue. So a lot of Black women do have endometriosis, and a lot of times we find it during fibroid surgery. So when we do a myomectomy or removal of fibroids via minimally invasive approach, one of the advantages of doing it laparoscopically is that you're also able to see endometriosis that otherwise would have been missed with open surgery. So we see endometriosis at the time of myomectomy quite a bit. I think our recent data analysis showed that over 40%, close to 50% of women had endometriosis at the time of a fibroid removal. And some of these women didn't have any symptoms, or maybe they thought they associated all of their symptoms with the fibroids. And because a lot of the time symptoms sort of blend together, you can't really tell what's causing what. So I think the main thing is that we always have to have high level of suspicion when it comes to endometriosis and not dismiss pain, even if it sounds atypical, or if the patient doesn't fit the mold of who we think endometriosis of who we think should have endometriosis.
That's a really good point. And I'd just like to add in terms of the, just to give you some numbers on the coexistent rate of endometriosis and fibroids. Our research team at CIGC recently had an abstract published at an international congress. It was the World Congress on Controversies in Obstetrics, Gynecology, and Infertility. And the topic was basically looking at the prevalence and risk factors of coexisting endometriosis in all patients that underwent a myomectomy. So those patients that had fibroids, just what Dr. D was talking about. So we looked at over close to 400 patients and found that the coexistent rate of endometriosis. So how commonly was endometriosis found in these fibroids patients? And it was in 45% of the cases. So close to half of the cases had endometriosis. And we concluded in the abstract that failing to remove endometriotic lesions or failure for complete removal of endometriosis during the myomectomy may lead to more continued pain, infertility, and eventually reoperation. Now I have a question for you, Dr. D. As a surgeon, when you go in for a myomectomy, you're going in with the intention of removing the fibroids. Is it kind of like common sense that when you look at the uterine cavity, endometriosis pops up and you're like, oh, it's like, I'm not a surgeon. So is it like obvious for you when you go in? Can you easily identify the endometriotic lesions, or do you really have to intentionally look for it?
On laparoscopy, it is pretty obvious. So you're actually looking inside the pelvic cavity, right? Not the uterine cavity, but the pelvic cavity. So on laparoscopy, it is pretty easy to identify endometriosis, but you have to know kind of what it may look like, because not all endometriosis lesions look the same. And on our website actually has some really good, actual photos from surgeries of different lesions, but it can look like scar tissue. It can look like that, very typical gray or brown or black lesion, but not always. It can look like a clear, more like almost like a blister. So it can be, scarring, severe scarring. So you definitely have to be able to recognize it. But certainly, if you know what you're looking for, it is pretty obvious. With laparoscopy, with open surgery, it's different because you don't have access to the back of the uterus, which is where most endometriosis lesions are located. Mm-hmm. So that's the advantage of laparoscopy and using the camera.
So just to reiterate, you really do have to be an experienced GYN surgical specialist to remove these endometriotic lesions during a myomectomy, and just on its own too, in order to identify it.
Absolutely. And just to add to what you just said, I just today actually saw a patient who had a laparoscopy done by her local GYN, and at the time of the laparoscopy, endometriosis was seen and recognized as being endometriosis, but it was not removed. And obviously that's very frustrating to the patient, and most likely the reason it was not removed was because it was near some vital structures that the surgeon didn't feel comfortable removing, which of course safety is the primary goal, but that's a reason to go to a specialist, because a specialist is just more used to removing or doing more complex surgeries and are more likely to be able to remove a lesion. So
absolutely. And just to add to your previous point on, and that was actually the next myth, endometriosis is found at higher rates in white women and fibroids are found in higher rates in Black women. And you addressed that already in saying that's not necessarily true. And there was actually a study done last year in 2019 It was a systematic review that was published in the International Journal of Obstetrics and Gynecology. And the researchers there found that Black women are only about half as likely to be diagnosed with endometriosis compared to white women. And I just want to put the emphasis on the language half as likely to be diagnosed. So they didn't say Black women are half as likely to have endometriosis, but half as likely to be diagnosed, because we know the only way to definitively diagnose endometriosis is laparoscopic surgery. So the authors then went into explaining that this myth exists because most of the existing studies that are investigating the mechanisms of endo mainly only include white women. So overall, there's limited literature exploring the role of race in endometriosis. And so when you think about it, one's race or ethnic background and socioeconomic status influences one's ability to access healthcare and in turn obtain a specialist referral in order to be properly diagnosed and treated. So we have to keep that in mind. It's just, in order to be diagnosed with endometriosis, you have to have laparoscopic surgery. And then there's that whole issue of access to care. How am I going to get diagnosed? Who am I going to go see? Like, do I have access to a GYN surgical specialist?
Yeah, I think, there's many factors that lead to misdiagnosis or underdiagnosis of endometriosis in Black women. I think, one, definitely providers, not thinking endometriosis when a Black woman walks through the door. Another thing is, different, how, patients themselves, their family members, their community around them treats pain, or what's normal and what's not normal, telling, your daughter that, painful periods are a normal part of women, and doctors tell women that all the time as well. It may not be the right approach, because you could be saying, oh, it's normal, when in fact, this young woman is already suffering with endometriosis. But I definitely found, whether it's anecdotal or not, but in my surgical experiences, that when I see even young Black women with endometriosis, a lot of times it's extremely advanced, more so than in white women. And again, I don't know if it's just kind of normalization of the symptoms, right? Saying that pain should be there, by, again, family and providers alike. Or there's some other component that's making the progression of the disease faster.
Absolutely. We have an audience question from Raman Deep, and she's asking, how long does it take for endometriosis cysts to come back after laparoscopic abdominal myomectomy?
After abdominal myomectomy?
She says after laparoscopic abdominal myomectomy, laparoscopic assisted.
Oh, okay.
Myomectomy.
Yeah, I mean, so how fast does an endometriosis cyst come back, basically, whether it was found or removed during a myomectomy or during some other. So, I mean, there's different factors. There's definitely evidence showing that younger women tend to have a faster recurrence than an older women, and that may be because, again, the ovaries are more active, there's higher estrogen production. It also has to do with how the surgery was done, whether the entire, cyst was resected, whether there were already other small cysts within the ovary that weren't identified. Certainly the condition of the ovary, but it's not uncommon to have recurrent endometriosis cysts. Those are tricky. I would say that the most important part about cysts and endometriosis is that the surgery is not delayed to a point where you basically have no ovary left, where there's mostly endometriosis cyst, because then it's very difficult to save any significant portion of the ovary, because that ovary has already been destroyed. But at the same time, if you have recurrent cysts every time you do a surgery, inadvertently removing some of the normal ovarian tissue. So you can end up with very little ovary. So it requires sort of constant follow-up, maybe some suppression with medications to kind of prevent recurrence and avoid repeated surgery on the ovary, because again, that lowers the egg production and lowers chance for fertility if that's the goal.
Absolutely. So let's jump right into our next myth. Endometriosis only occurs in the pelvis. So although the pelvic cavity is the most common location for endometriotic implants, and Dr. Dan, I'm going to ask you to chime in a minute, we know that endo can occur in areas beyond the pelvis. It's very rare, and it's also difficult to diagnose. So the most common atypical locations for endometriosis, in other words, the most common uncommon locations for endo, are the GI tract, gastrointestinal tract, urinary tract, the lungs, the umbilicus, breasts, pelvic nerves, as well as abdominal surgical scars. In 2015, there was actually a study that was published in the Journal of Obstetrics and Gynecology Science. And the researchers looked at the pathology reports of close to 1,400 women who underwent laparoscopic surgery for endometriosis. And they found that the predominant location for endometriosis was the ovaries. And that was suspected. About 96% of those cases had it on the ovaries. And only 4 cases of endo were found on the GI tract, and 2 cases were found in the urinary tract. So Dr. D, where have you found evidence of endometriosis in your patients?
Yeah, I think we need to clarify. So as far as when we're talking about found in the urinary tract, endometriosis is very common to find on the surface of the bladder. So kind of there's bladder, and then you have peritoneum, which is this shiny layer that's sort of like a see-through blanket that covers all the internal organs. And so you can have the implant on the peritoneum that overlies the bladder. That's very, very common. Same thing with the ureters, which are part of the urinary system. They're tubes that go from the kidneys to the bladder. You can have endometriosis on the peritoneum overlying the ureters. Same thing with the bowel. It's very common to have endometriosis near the rectum. So it's not growing into those structures, but it's definitely very close or kind of overlying that peritoneum of those structures. Appendix, I've seen it in the appendix. Diaphragm, which is sort of what divides our abdominal cavity from the chest cavity. So you can find it in a diaphragm, and usually patients will have referred shoulder or under the ribcage pain during their period. And that can be, easily excised or burned off. The lungs, that's very rare. So typically patients will present with, fluid in their lungs, and when the fluid is removed, it's like a dark blood, which is more like endometriosis. As far as the belly button and the prior abdominal scars, so those, I've seen those as well. So that's typically implantation from the surgery. So one of the somewhat common instances is C-section. So someone who had a C-section and then developed this painful lump that gets bigger every month when they have a period. So that's an endometriosis implant in the C-section scar that grows with time and actually fills up with blood. So it's like an endometriosis cyst in the abdominal wall scar. And those can be just isolated to that area and not have endometriosis anywhere else. So those need to be excised because they don't go away, and they typically don't respond to medical treatment. Belly button, the same thing. So if somebody had prior laparoscopy, during that laparoscopy, you could have had an implant of endometriosis that implanted in that laparoscopy incision. So, and those are also pretty easy to diagnose because you would have, you could have blood coming out of the belly button during the period, or some kind of bloody or brown discharge, and those again just need to be excised or removed. So there's definitely various locations. I think a lot of patients who think, okay, I might have endometriosis, and that I may, and they start going online and start reading about all this crazy, endometriosis, and start thinking, oh my God, I have bowel symptoms, I have urinary symptoms. What if I have endometriosis growing into my bladder or bowel? Most of the time it's not the case, and that's good, because that's very severe endometriosis. But it's that one time when it is the case, it's very important to recognize it and address it, because if you have endometriosis actually growing into the bowel, you're going to need bowel resection. You may need to have reimplantation of the ureter because it's growing into the ureter and causing kidney damage. So that's already a sign of extremely, extremely, extremely severe endometriosis, and typically due to delay in care.
When you do, I'm just curious, let's say you go in and there's endometriosis on the uterus, you excise that. If you notice endo on the ureters, is that something you take care of, or is that something a uro-GYN specialist takes care of?
No, we take care of that. Yeah.
Oh, okay.
Right. Yeah. So it's just a matter of dissecting that shiny layer, the peritoneum that has the endometriosis, and dissecting the ureter away. But even in the cases where we have endometriosis growing into the ureter and causing complete obstruction, so ureter is a very thin structure. It's like a noodle. So it has very small caliber lumen. So any type of blockage will then cause permanent kidney damage. And I've seen patients completely losing their kidney function on one side because of the blockage of the ureter. So in those cases, the ureter, that abnormal portion of the ureter, has to be actually cut out, and then the normal end reimplanted into the bladder. So kind of like bypassing, right, the block, just like it's the same as the heart bypass, right?
Can I ask, do you receive, as a GYN specialist, do you receive special training to be able to do that, or are OBGYNs as well able to perform?
No, so a lot of these like extra dissections, that's more done by GYN oncologists. So GYN oncologists do special training, extra years of surgical only training to be able to dissect the ureters, to be able to, reimplant ureters or doing bowel resections. So that's definitely done by a specialist, which we do in our practice. But you would not expect an OBGYN, a general OBGYN to be able to do that.
Okay. Thank you, Dr. D. We have a few audience questions. So first one is from Rashia. She says, Army service member here. Our medical providers pushed for long-term, up to a year, use of Lupron treatments. Is that a thing, Lupron depot or
Depot.
Lupron depot treatments to prevent growth. Before Lupron, I didn't have any issues with cysts or masculine hormones. 8 months after my last shot, I was diagnosed with PCOS. Can those treatments for endo cause other GYN issues to develop?
So PCOS is typically something that is there from the very beginning. So it's a dysfunction where a woman doesn't ovulate regularly, and sometimes they can lead to overproduction of some male hormones and things like that. But that would have been already there prior to Lupron therapy. Now the question is, why do Lupron for a year? So typically, and again, every case is going to be different, but typically you would not have somebody on Lupron for that long. So, that's, I think, where the I'm not certain whether, you know, the duration of the treatment is really the right thing. You know, was there surgery already done? And is this in response to what was found during surgery? Or is this the first kind of treatment option? So I think there's a lot of things going on, but I would say Lupron does not cause PCOS, but certainly prolonged Lupron production, use can cause osteoporosis, which is the, you know, thinning of the bones, and some other issues. So I think that needs to be revisited.
Absolutely. We have a question from Marissa. She's asking, how does endometriosis end up in other places in the body? And who treats endometriosis in places like, for example, the lungs? So I know you went over we went over the different areas of the body that endometriosis can take place, but how, for example, how does it end up in the lungs? And in very rare cases, I read an article once that it ended up in the brain.
Mm-hmm. Yeah. So, you know, obviously the retrograde menstruation theory then doesn't quite work because lungs are in a completely separate cavity. So directly those salts couldn't have traveled to the lungs through the fallopian tube. So then, you know, the lymphatic, right, is another kind of passage system, kind of like cancer. You can have metastatic cancer from the uterus to the lungs. So maybe that same mechanism. But as far as the treatment, so, you know, in cases of very advanced endometriosis, we have to go back to the root issue, which is the estrogen production, right? So the endometriosis thrives because of the estrogen. And in cases of very severe endometriosis, when it's invading into other organs, just saying we're going to go in and excise it is not really an option, because sometimes there's already, you know, so much damage going on, you can't, you know, remove entire organ. And so you have to then eliminate the source of estrogen, which is the ovaries. So typically in cases which are very severe, where endometriosis has metastasized, right, has traveled so far beyond the pelvis, we recommend removing the ovaries as the, you know, definitive treatment, and not trying to do conservative management, which is more appropriate for less advanced endometriosis.
Okay. Severine, and my apologies if I didn't pronounce that right. She's asking, could you talk about endometriosis of the bowels? I had a laparoscopic surgery 2 weeks ago where they confirmed extensive presence of endometriosis on my ileum. I can't pronounce that, Dr. D, again. There you go, cecum, part of my bowels. And oh, there you go. That's a word for you, Dr. D, again.
Yeah, so resection, right? Ileocecal resection was required. Yeah, so that's you know, very extensive, right? So they had to remove part of the bowel to be able to remove endometriosis. You know, that's concerning again for very advanced endometriosis. And I'm assuming there were other areas that wasn't just, you know, localized to the bowel, that you would need really to eliminate the estrogen production, which is the ovaries. And sometimes we have to do it in young women because, you know, otherwise you're not able to stop the disease, and it can progress and spread into the vagina, to the bladder, into the ureters, blocking the kidneys. So it's like a local spread. And, you know, not only, again, the lungs would be more rare than the local spread of this disease. And you have to eliminate the kind of the ignition, which is the estrogen.
Okay, great. Thank you, Dr. D. Now let's move on to our next myth, which is endometriosis is only a bad period and pain only occurs a few days per month. So Dr. D, could you talk to us a little bit about the symptoms and whether or not that's true? It only occurs a few days a month, the pain of endo?
No, endo can be very different, you know, and that's why, again, it's important to kind of listen to each patient and have a high level of suspicion. You know, worst thing that can happen, we do laparoscopy and we don't find any endometriosis. And although it may be disappointing, to that patient, just think of how many other patients we can help with the, with the correct diagnosis. So it doesn't have to be, only during your period. It can pain be most of the month, right? Because endometriosis, remember, creates inflammation that then causes scar tissue. So someone who has, endometriosis growing into the bowel, although sometimes those patients can have very little pain, majority of the time when it's that advanced, the pain is going to be more constant. Pain can be mid-cycle instead of, around ovulation instead of being during the period. Sometimes patients will be on hormonal treatment, which will stop their periods, or let's say they take birth control pill continuously, which leads to no periods, but they'll still have pain. You could have primary symptom could be pain with sex, or pain with bowel movement, or pain with urination, bloating. There's different things, but typically, when the pain tends to be cyclical and not random, you always suspect endometriosis. And sometimes patients will think they have IBS. So endometriosis can mimic other conditions. And again, it's very important to have high level of suspicion.
Exactly. I was just going to say, a lot of the symptoms that you're going over really overlaps with a lot of conditions like pelvic inflammatory disease, and which is why it takes an average of 10 years for patients to be diagnosed with endo, which is more of a reason to seek see a GYN specialist earlier on in the process when you're experiencing those symptoms. Because you don't know, just because you're experiencing those symptoms, you can't self-diagnose and say, I think I have endo, because it could be a lot of other things, but that's why it's so important to see a GYN specialist. Right.
And that reminded me, there was a patient I spoke with earlier, and she was having only bowel issues. And so she had an imaging and the MRI that actually showed very severe endometriosis, which, typically imaging can miss it and can show nothing, can show that everything is normal. But her disease is so advanced that it was even showing up on the MRI. But, her reaction was, well, I don't think I have endometriosis because I Googled endometriosis and I don't have any of the symptoms that people say. So, it can go both ways. You could have no pain and have really bad things going on. So I would definitely say if there's stuff seen on imaging, it's there in some capacity. And again, laparoscopy is going to be important to confirm what is going on in there, because you could be missing things that are just continue to progress. And by the time you have symptoms, it may be too late to save some of the organs.
Right. Absolutely. Good point. I want to bring up the slide on the stages of endometriosis so our viewers can see the different stages, and if you can briefly just go over the different stages. And while you're doing that, if you can answer this question of, just because I have more severe symptoms, does that mean I have stage 4 endo, for example?
Yeah, so the stages a lot of times don't coincide with the symptoms. So you can have somebody who has severe pain, they're in the ER every month, and they may have, stage 1 or minimal endometriosis. Because that level of endometriosis still can produce a lot of inflammation and a lot of pain. So just because there are a few implants doesn't mean that the pain is not there or it's not real. And certainly, prior to doing laparoscopy, you don't know whether it's 1 or 4, right? And ideally, when it comes to diagnosing endometriosis and surgery being effective and treating it, is you want to diagnose it in the first couple of stages. Once you get to stage 4, you sort of you're sort of missed the ball in terms of surgery being kind of the definitive treatment. And when I mean surgery, I mean conservative. So conserving the uterus, the tubes, and the ovaries. So someone who wants fertility, let's say this, 18-year-old who's had pain, right, and did not get laparoscopy until now. If I find stage 4 endometriosis, I'm very limited as to what I will be able to do. So as you can see, so there's these lines connecting the tubes to the ovaries, to the rectum here underneath the uterus. These lines are, scar tissue. So the inflammation has been so severe that it caused tissue to fuse together. So in this patient, infertility is certainly a huge factor. And really, you're not talking about excising disease anymore. We're talking about separating this fused tissue that's already damaged. So in this stage 4 picture, this tube is likely permanently damaged. It's something that you cannot reverse. But compare that with stage 1, basically all the anatomy is still normal. You just have these small implants that can be easily excised. So, I think, the patients always want to know, well, am I stage 1 or 2 or 3? The important thing to remember is kind of the involvement, right, of the reproductive organs and the damage that's already occurring in the later stage versus in the first stage, second stage. All these implants are very resectable, and the surgery is going to be, I'm not going to say curative because they can still come back, but there's certainly very positive, good outcome, right? Good prognosis, that the surgery is going to help with the pain, the fertility is going to be improved versus stage 4. If I do laparoscopy and I see stage 4, definitely medication therapy that stops the hormone production, like the Lupron therapy, or potentially even having to remove the uterus and the tubes and the ovaries to stop the progression of the disease.
Okay. And I have a question from Mary, and she's asking, can I change to, so let me see if I understand this. I believe she had she was diagnosed with stage 4 endometriosis, and she's asking, can I go back to stage 2 after being on BCP?
So,
and surgery?
Yeah, so birth control pills don't make endometriosis go away. So if somebody has stage 4 endometriosis and they're just put on the birth control pill, they're not going to regress to stage 2 because you still have all the estrogen production. The birth control pills, they stop ovulation, so they stop these spikes of estrogen, so there may be some less inflammation, but overall the disease is still there and it will still progress. So if there was some excision, some extensive excision done, right, and lysis of scar tissue, and then maybe some suppression with stronger medications, and then the birth control pills, and then you do laparoscopy, you may see a great improvement. I've definitely seen that, but just the way it sort of got there in the first place, right, the stage 4 occurred, it can still progress again. So patients with severe endometriosis, or even not severe, any endometriosis, will require constant follow-up. Just doing one surgery and excising it, it's not one of those conditions that you can say, I'm fine now and everything is gone. It can come back, it can progress, it can be worse after years than it has been before. But usually improvement is with surgery and suppressive therapy. You wouldn't just expect it with birth control pills.
And I know later on you're going to go into just the overall management of endometriosis and how lifestyle choices play a role in that. But before we do, Chrissy wanted to know more about the symptoms of endometriosis on the bowels and the bladder.
So with the bowel, usually it can just mimic IBS. So, somebody who has bloating, pain with bowel movements, especially during periods. You can have sometimes blood in the stool, and that's just caused due to inflammation and the sloughing off of some of the lining of the bowel. So it's not necessarily that you have endometriosis growing through the bowel, right? Because that would be a sign of much more advanced endometriosis. But even with some implants near the bowel can have that effect of bowel issues, bowel symptoms. So definitely if IBS has been suspected in the past, but also your symptoms are very cyclical, endometriosis is a possibility. Bladder, it can be, frequent urination, painful urination. Again, it typically tends to be cyclical around the cycle. But endometriosis is suspected in those cases. Also, there's a condition that's called interstitial cystitis, which is very common and commonly coexists with endometriosis. And that's sort of inflammation of the lining of the bladder, which produces symptoms similar to a bladder infection. So, pain, frequency, kind of irritation. So that's not uncommon, and that, needs to be investigated as well.
Again, a lot of overlap of the symptoms between different conditions. Could you talk, you mentioned earlier one of the symptoms of endometriosis may be infertility, and when you were going through the stages, you mentioned how if there's endo on the fallopian tubes, it can basically compromise fertility. So could you talk a little bit about infertility as a secondary condition to endometriosis, and why some people may have a difficult time becoming pregnant with endo?
Absolutely. So infertility could be the only symptom of endometriosis. So certainly if you've been unable to get pregnant, right, and all the evaluation, the fertility workup has come back normal, endometriosis is certainly should be at the top of the list, right? So some people will call it unexplained infertility. But laparoscopy should be part of that workup, because typically when somebody has trouble getting pregnant, we check the hormone levels, we check the ovarian reserve, which is the number of viable eggs, within the ovaries. We check the fallopian tubes, we do semen analysis, all these things, but typically laparoscopy is not traditionally part of that workup, but it certainly should be, and again, without focusing too much on the symptoms. So you can't say that, because you don't have horrible periods, you can't have endometriosis. You certainly can. And even mild endometriosis can, produce inability to conceive, because it creates, again, this inflammation, right? So even if it's not causing scar tissue, even if imaging, tests for tubes, everything looks picture perfect, it still doesn't give you the same insight as a laparoscopy would. So just inflammation can create negative environment for the eggs, and so which can result in infertility. And there are studies even showing that with in vitro fertilization, the success rates are lower with endometriosis, right? So it's a little bit counterintuitive, because you're thinking, well, you're bypassing everything, right? You're taking the egg, you're taking the sperm, you're creating an embryo, and then you're putting it directly into the uterus. Why would anything outside of the uterus, any inflammation or whatever, impact that? But it actually does. So I think just having infertility, unexplained infertility, it's a good idea, even if you're going to do IVF, to do laparoscopy, to look for endometriosis and remove it to improve the chances.
Absolutely. So our next myth is alternative treatments like herbal supplements, vaginal steams, and detox pearls can cure endometriosis. Now, before we get into this, I want to just acknowledge that as a woman with debilitating pain, painful periods, heavy bleeding, it's affecting the quality of your life, it's impacting your work, your school life, your family life, of course you're going to find everything and anything to try to alleviate your symptoms and try to cure your condition. And the first thing we go to is often, when it's not Western medicine, it's alternative treatments. And I don't think there's anything wrong with that. However, and there's so much respect that needs to be given to ancient Eastern medicine practices, because it's been around longer than Western medicine. However, it becomes tricky when you read claims like a certain procedure or a certain product cures a condition, because when you make a claim like that, it needs to be backed up by research. And unfortunately, there's no research that supports that these treatments, vaginal steam, pearls, cure endometriosis or any other GYN condition. So let me start by just defining what both of these are. Vaginal steams are steam baths that are filled with various medicinal herbs. And the concept is that the heat from the steam is thought to relax and open the vaginal walls to allow the essence of the herbs to travel up through the vagina and into the gastrointestinal tract. So essentially, these medicinal herbs are supposed to treat those endometriotic lesions that are on your uterus and any GI issues that you're experiencing. With the detox pearls, they're medicinal herbs that are tightly wrapped in a cotton cloth in the shape of little tiny pearls, and then they're inserted into the vagina where they can remain there for up to 2 days. So proponents of vaginal pearls claim that the pearls absorb any toxins or bad bacteria or blood clots in the vagina. And then after that 2-day period, the pearls are removed along with all these supposed toxins. So again, there's no scientific evidence for both of these methods and in fact, they may do more harm than good, especially the vaginal detox pearls. With the vaginal steams, they're both ancient Eastern medicine practices, and they're thought to, the purpose is to provide symptom relief for painful periods, heavy bleeding, and GI symptoms. But we have to keep in mind that the vagina is already a self-cleaning organ, and the cervix makes mucus, and the purpose of mucus is to flush out all potentially harmful bacteria that are in the vagina. So the entire female reproductive system is a detox system in and of itself that already contains good bacteria for its own protection. So using any outside elements that are meant to detoxify the vagina may actually do the opposite and eliminate any good bacteria we have and introduce toxins to the vagina that cause infections. So when you actually go on YouTube and you see the testimonials of people using these detox pearls, they show you the end result, and they show you just all the discharge and stuff that comes out of the vagina, and it's all this like discolored discharge, and they're saying like, hey, look, this actually worked because this is all like the bad toxins and the blood clots, not realizing that, and Dr. D, you can actually add to this in a minute, if you have discolored discharge, that can highly likely be a sign of infection. So leaving any foreign object in the vagina for days can lead to toxic shock syndrome. And I'm sure a lot of you heard of that applying to tampons as well. And it's a life-threatening condition. It's bacterial infection. And while vaginal steams may be less dangerous than pearls, the claims that they can cure endometriosis and any other GYN conditions are just not true. So if you guys want to learn more about why these types of treatments don't work, you can check out the CIGC blog post on this topic at www.innovativegyn.com and then /Endo Mythbusters. I think we have a banner up there as well. So Dr. D, could you weigh in on the herbal supplements and other alternative treatments, one that you heard from your clinic? Your patients come to you, like what are they using for alternative treatments? And could you talk a little bit about the role of alternative treatments in endometriosis?
Yeah, I think, the main thing is separating something that's treating the symptoms versus actually treating the endometriosis, right? So we know that things that treat endometriosis, something that's going to alter hormonal production, right? So Lupron therapy, right, in extreme cases, or Alyssa, which anything that sort of blocks the natural production of the estrogen is going to be actually treating the endometriosis and preventing it from growing, versus treating the symptoms, which is if it's pain, right? So we're talking about pain management. So certainly things that have been shown to be effective, things like acupuncture, things that lower just inflammation, so certain even foods that lower the inflammation. Also, when we're talking about symptoms of IBS or GI symptoms, right? So if there are things that create more bloating and gas, that's certainly going to contribute to the symptoms that are already there. So it's sort of changing your diet based on that. When we're talking about urinary symptoms and potential for interstitial cystitis, there are definitely a list of foods that flare up that condition. So it's, again, avoiding those certain foods. So, but again, this is, we're treating the symptoms of pain. Pelvic floor therapy with some of the pain, with intercourse. So these are all symptomatic relief. And I especially, recommend it in women who, let's say we've done the surgery, we've removed endometriosis, but there's certain aspects of pain that are still there. And just as a continued kind of management, and to be able to reduce the frequency with which the surgery is done, if we can reduce the inflammation, if we can manage some of the symptoms, that's when that alternative therapy really is the most beneficial. But it should never be used as the only and as the sole treatment, right? If I have somebody who has just severe endometriosis with permanent, damage and it's continuing to progress, I'm not gonna say, just change some diet, do some diet modifications, and you're gonna be okay, right? Because that's gonna be detrimental. So I think I think a lot of those treatments are just, they're not going to cause any harm, but they may not be effective, and the disease will continue to progress and cause damage. So it's very important to be aware of what is going on. So
absolutely. And all those alternative treatments that you just mentioned, acupuncture, pelvic floor physical therapy, fitness training, and psychotherapy, they're all treatments that we offer at our new wellness center that
absolutely,
you mentioned at the very end.
Nutrition, is very important. And, I think even when it comes to those therapies, it's important to have the provider who's educated on the topic of endometriosis. Right. Because, for example, not all physical therapists specialize in pelvic floor physical therapy. I mean, you can have physical therapy on your knee or your shoulder, and then certainly there's not much relation there to the pelvis. So really working with the providers, the advantage of, for example, our wellness centers, the providers are focused on GYN health. They're focused on women with pelvic pain, with some pelvic floor dysfunction, or other issues with infertility, things like that. So the treatment is catered to those issues. It's not just kind of one blanket approach.
Absolutely. We have a audience question from Mary again. She's asking, what are the preventative treatments for recurring endo after surgery?
Preventative treatment for recurrent, yeah. So hormonal treatment is one of it. It depends on the severity of endometriosis. So if I have someone who has stage 1 endometriosis, the surgery was done, it was successful, all the lesions were removed. Even if there's still some pain after the surgery, that's someone I may put on birth control pills. I know that birth control pills do not prevent endometriosis from growing, but because of the disease was not very severe, I wouldn't necessarily put that patient on, complete estrogen, block, which is the Lupron or the Orilissa. So birth control pills, right? Eliminate ovulation, eliminate the spikes in estrogen levels, and eliminate some of the inflammation. So that might be sufficient for that patient, but again, continued close follow-up. So every 3 to 6 months, kind of following up and reviewing the symptoms to see if there's any kind of slow progression or worsening of some of the symptoms. What are they? did we miss something? Is there maybe adenomyosis within the uterine muscle that we have not diagnosed? So follow-up is definitely extremely important, because if there's no follow-up, then we can't manage or treat this disease, because it's a chronic disease. Just like somebody with high blood pressure or diabetes will require long-term follow-up. Just because they're put on medication doesn't mean that they don't need constant kind of review of symptoms and seeing what's going on. But if it's endometriosis surgery that revealed more extensive endometriosis, then that's where we put on hormone suppression, and then possibly talking about another surgery to see whether this treatment has been effective.
Okay, great. So let's go on down to our rapid fire real quick. Let me find our rapid fire myths. Let's see. We had a bunch of myths that were submitted prior to today's event from different people. So I'm going to read the myth, Dr. D, and you're just going to tell me if it's fact or fiction. Okay? So Dakota says, taking both an estrogen and progesterone birth control will help.
Can help with some of the symptoms. Yeah, so these are just typical combination, either birth control pills, patch, or vaginal ring. So that can help with the symptoms, yes.
Okay. Rashia is saying endometriosis can only be managed by birth control.
No. So if surgery has to be as part of the diagnosis and initial management of endometriosis, removing of endometriosis, and then depending on the stage and the severity of the symptoms, birth control can be part of the management, to control the symptoms, but it's not curing, it's not removing endometriosis. Birth control pills do not do that.
Okay. Rashia is also saying, I have a few from Rashia here. Long-term use of Lupron depot, 6 months to 12 months, can lead to the development of cysts.
So Lupron is a medication that blocks the estrogen production. So typically during that time, there is no ovulation. The ovarian function is completely shut down. So there typically would not be any cysts. Now, you can have cysts that grow in the postmenopausal women. So it certainly doesn't prevent tumor growth in the ovaries, but it wouldn't, you wouldn't see any normal functional cysts within those ovaries. So, Lupron doesn't cause cysts. So certainly any cyst that's there during the Lupron therapy would need to be investigated.
Okay. The rest of these are all from Rashia, by the way. If you have endometriosis, more like the chances of you having adenomyosis is high as well.
Yeah, so adenomyosis is just endometriosis in the muscle of the uterus. So it's not uncommon. It's actually more common than people think. And a lot of times it goes undiagnosed, especially in women with fibroids, because fibroids are seen on imaging, and kind of the focus becomes the fibroids being the ultimate cause of all the symptoms. Adenomyosis can cause abnormal bleeding and pain. And hysterectomy is the only effective treatment for adenomyosis. So I know there were some questions earlier about hysterectomy. That's definitely is an option for women who are not desiring fertility, and maybe a better option than just excision surgery in some cases for more complete removal of endometriosis, especially if adenomyosis is suspected.
Okay. Endometriosis is prominent in women who started their period at a younger age than normal. I'm assuming that's what Rashia meant.
In terms of the time, right? So if someone developed endometriosis early on and it continued to progress, then yes, over a 20-year period, it can be pretty severe. But it's not as clear cut, and I don't think, I'm not sure in terms of data out there, because you would have to do laparoscopy, on a number of patients from early age to check on the progression. Sometimes we do laparoscopy at age 18 and endometriosis is already severe, versus somebody with laparoscopy at 25 and there's very little endometriosis. So it's hard to kind of pinpoint the timing. I think definitely in some women it just progresses faster than in others. So it's not just the time, how long it's been there. It's hard to predict the speed of progression or whether it's going to progress. You can have a 45-year-old with endometriosis that has a very mild disease.
Last one from Rashia. She says endometriosis can cause bowel issues. You may have briefly touched on this earlier.
Yeah, absolutely. So if the symptoms of IBS, pain, constipation, so all of these pelvic organs are all close to each other, and just general inflammation of the pelvis can mimic a lot of these conditions and can definitely cause bowel and bladder symptoms and issues. Absolutely.
Okay. And then our last myth before we head on to close this live out is a hysterectomy is the only way to relieve yourself of endometriosis pain. Is that true?
No, it's not true. Again, it's going to depend on so many factors. How severe endometriosis is, where endometriosis is located. I mean, certainly if there's endometriosis in the uterus, then yes, hysterectomy, should be considered. If there's severe endometriosis, stage 4 endometriosis, certainly yes, hysterectomy and removal of the ovaries should be considered. So, if there's bleeding as one of the symptoms, right? If there's very heavy periods, in addition to the pain, hysterectomy, should be considered. And, or if this is the patient desiring fertility or not. So, there's definitely multiple factors. So it's hard to say rule of thumb, but typically, with adenomyosis, for example, hysterectomy is going to be most likely, the best treatment.
Right. Well, Dr. D, we have reached the end of our live. So do you have any last comments before I close this out?
Well, I think that's just, pain is not normal, right? And regardless of the character of the pain, or whether it fits the mold of, what you read online, I think it always should be investigated. And, the biggest mistake is that, not diagnosing something soon enough, and then, having to deal with permanent damage and having to remove, portion of the organs where potentially maybe it could have been avoided had the diagnosis been made sooner.
Absolutely. Thank you so much, Dr. D. And to our viewers, this has really turned out to be an extremely popular topic today. We had so many comments and questions come in that we're going to do a part 2 of this live at a later date. So if your question wasn't answered, don't worry. We'll be sure to answer it in part 2, so stay tuned. And I just want to give a shout out to Dakota, who submitted a lot of questions that unfortunately we couldn't get to today, but I promise we'll get to it in part 2. We'll have a recap of this event published on our blog next week. Both a written article and a recording will be available at innovativegyn.com/endo Mythbusters. And before I close out, just one more thing. I just wanted to talk about the Wellness Center that just recently launched. So our wellness, the CIGC Wellness Center, was designed with you in mind, women with endometriosis, fibroids, and chronic pelvic pain. Whether you are preparing for GYN surgery or you're looking for a non-surgical approach to manage your symptoms, you'll find that the Wellness Center offers therapies targeted towards your health goals. At the Wellness Center, we offer pain management, acupuncture, pelvic floor physical therapy, physical training, nutrition counseling, and psychotherapy to help treat and manage your complex GYN conditions. So if you're interested in learning more, please visit www.innovativegyn.com/wellness-center. Thanks so much, everyone. And thank you again, Dr. D.
Thank you. Thanks. Bye-bye.
Bye.
Bye.